evening, dear Foxians and all viewers watching this daily Foxy podcast Gyan Pravah series. I, Dr. Brisbala Tiwari, Chairperson Environmental Committee, welcome you all for today's 336th episode. And today, with us having guest speaker, none other than Chairman ISAR Embryology, Dr. Charudat Joshi. We welcome you, sir. Before that, I invite our President Na bhuto na bhavishyati. If I say this word, it goes very well to ma'am's introduction. For the first time in the history of Foxy, this meticulously designed daily podcast series on various subjects for the women's health, for the betterment of society, Madam has planned. Brain behind this beautiful concept is none other than our visionary president, Madam has done so many projects. She is working 24 into 7 for the betterment of women's. Madam is very spiritual. She is combination of researcher, clinician, academician, surgeon, and what not. Ma'am's contribution extends beyond operating room, and Madam is
Brijwala, not my introduction. I request you. I'm so glad today. I'm pushing myself in Brijwala. This podcast is of you and Dr. Charudatta Joshi. So I don't want enough words for me. Thank you so much. But Brijwala, I'm thankful to you. You got in Dr. Charudatta Joshi, sir, embryologist to your podcast, giving complete different vision. And sir, welcome to the Foxy platform. I know we are friends, we work together in ISAR, but coming on a Foxy and meeting, I met yesterday Abha Mujamdar. So it was so wonderful to meet the friends on a Foxy platform. She also never met me during my Foxy presidential year physically. We met for the first time, being good friends for years. Same is today with you. And this 351 podcast we are going to do is all thanks to my chairpersons. I just requested, asked them, and the way they have worked with dedication, passion, not a single chairperson has cancelled. The year is getting over. They did not cancel, they did not change, they just did it. And that is the commitment of them. So thank you, Brijwala. Thanks to you also. And thank you for
Ma'am, it's
getting.
your inspiration. Inspiration from you, madam. Only you and you. You inspired all of us for doing this work under your guidance. So thank you so much, madam. In
Thank you.
spite of your busy schedule, you are joining every day. You are blessing us, and your presence made us comfortable every time. Thank you so much.
Thank you. And sir, our protocol is I just joined to welcome you, showed the respect to the faculty who is taking out time for Foxy. But now I'm joining the viewers league and I will listen to both of you. So glad and see you in February in person, sir, in Ahmedabad. Thank
Yes,
you.
yes, ma'am. Thank you. Thank you very much.
Thank you, Vrishbala.
Thank you, ma'am. So, good evening and welcome, Dr. Charudat Joshi, sir. Let me introduce sir. Sir is a great personality and sir is postgraduate in life science, doctorate in life science, and trained in ART and allied procedures from Belgium, Singapore, Germany, and many more places. Sir has served as office bearer for various societies like ISAR, IFAS, ACE, SS, ISPAT, and sir is currently chairperson embryology ISA 2426 and sir is lab director RD Gadi Medical College Ujjain and sir is medical director Genes India ART Bank Indore and sir has done wonderful conference in Indore in September national conference
Thank you.
Cross
Thank you.
Connect. That was I think for the first time clinician and embryologist were all together and we witnessed more than 600 delegates attended it and got so many new things about the reproductive medicines. So I welcome you, sir, for this Foxy daily podcast series. And today we are doing 336 episodes, sir. So we are doing every day, and there will be total 351 till 13th January. And on 14th, the next team will take over. So I welcome you, sir.
Thank you, madam.
Sir, I know you are working for this embryology since decades, more than 2, 3 decades, and you have seen so many changes from past, present, and you are going to witness future changes in embryology. And it is said that IVF lab is heart of IVF unit, and embryologists are the silent worker behind the scene, and they are the most important part for the success of IVF. If any couple is coming to us for male fertility, infertility, or female infertility, it is the joint thing between clinician and embryologist. So embryology lab is really heart of IVF unit. So, sir, just want to ask you, what drew you to embryology to come to this field,
Good.
life science, and you have done doctorate in that, and so many countries you visited. So, just want to ask this.
Yes. Now, this is very good question, and believe me, this was never. I never thought of being an embryologist because that was not in the picture when I did my post graduation in '93. So, to be honest, what happened that I saw an advertisement in newspaper require reproductive biologist. That is what is the position. So I thought I have studied reproduction. I am a biologist also. So probably this might be my place where I can work. And that's why I applied. I never know that this is an IVF center or here I am going to witness this new procedure and all. Because, it is in 90s, it has just started. So very few gynecologists were doing this procedure in India, and it was very restricted to their centers only. Not much of sharing, and not such kind of platform was also there. So I joined first center in '93 as a reproductive biologist and worked actually as a technician because there was no word embryologist coined at that time. It was just a reproductive biologist or a lab technician or reproductive biology technician kind of thing. So from that time, I am seeing the development. Now the world is totally different for an embryologist because embryology in itself is very well recognized branch now. Its due importance has been given. Embryologists are also now in forefront. They are also discussing. So lot of changes has happened in last 3 decades, and I think that was needed as per the time required because patient is also now very well aware and patient also wants to know about the embryos, their quality. So there should be someone. So as far as my attention to embryology is concerned, it is accidental to be very honest because I was never think. But once I entered in this, then I started feeling it is really very interesting, and the background was there, scientific background was there because life science is a subject. That's why in this ART guideline also they have kept this life science, postgraduate in life science. This is a minimum requirement because life science is a course designed for research. So you know genetics, you know immunology, you know cell biology, you know physiology, animal physiology, plant physiology. So all basic subjects are covered. So you know little about everything, and then you can just focus on one particular thing and go on. So this is how I started in '93 as an embryologist, junior embryologist.
So, sir, it's 32 years, and that was
Yes.
beautiful accident. As you said, you came accidentally. So, I must say that was beautiful accident that brought you to Indian ISAR as chairman embryology. So, that is really great thing that you were reading newspaper and you just saw, and there was no one in your family, and you
Yeah,
thought to come in this.
yeah, because that time the era when after finishing your graduation, post graduation, very first thing what people used to do is to find a suitable job, and that's why they started applying to different places. I have even applied for MR ship job also. I have applied for many jobs, but somehow it was a fate decided that I have to come in this field, so I entered in this.
So it was destiny to become embryologist and to
Correct.
lead the SR, Indian Embryology. So great, sir. And so you joined it and sustained your journey over the decades. Now it is more than 32 years. So that patient, what was the patient coming day to day? You are observing, and so I want to listen about that also. How you're
Yes, this is
sustaining it?
this is also very interesting fact to know because as I said, when it all started in 90s, there were very few doctors who were involved with this infertility treatment procedure in India, and there was a kind of very what you say constricted kind of thing that no one should else knows about this new technology. Is there was lots of privacy and everything was maintained in it. And then, like if today, if you want, you just go type on Google, want to see and or visit an virtual IVF lab. You see 10 different lab videos are there, and you can very well. But in 90s, when we thought of like if I think in 93 that I want to see an leading IVF lab of the country, it was not allowed because there was an limitation that okay we don't want to share much of this thing. But as far as I am concerned, I feel that once I entered in, then when I saw that, okay, this is reproductive biology, this is reproduction. Till now, we have just seen in picture, in books only, we have studied only theoretical part, but this is something which was actually my knowledge, which I got in MSc course, was practically applied. So I started taking interest, and it was really very interesting field as I go in and in. At that time, ICSI was not that common in procedure, it was just IVF. And when I talk about this, that particular time period, people don't believe that without CO2 incubator, we used to do the IVF. And that is happened in India with Dr. Ghosh Dastidar's place also with Dr. B.N. Chakravarti when that started because at that time CO2 incubator was not in concept. So what we used to do is we used to use an desiccator. A desiccator is filled with water. On that we put a petri dish, and petri dish contains media layered with oil, and we just put sperm and egg inside, close it, seal it, and volume, according to volume, 5% CO2 is added to it with the help of a tube, and it is sealed. And that entire thing goes inside incubator, normal incubator, bacteriological incubator, 37 degree. That's how our CO2 incubator works. And then after 2 days, we used to take it out, denude it, whatever is there, embryos are there, we used to transfer them. And surprisingly, sometimes we get pregnancies in that condition also. But that was the time when it all started. And now you have everything remotely accessed. You can sit at your home and you can observe your embryos developing in the incubator. Manipulator, when it came, it changed totally the scene because there was always an fear of failed fertilization. So that thing is overruled with the help of the 6C. Then once this this side continuously motivated me to go more and more into it. Then I started thinking of going abroad for training because that time in 2000, not much of the information available in India. So started gathering information, visited few places, we saw work over there, and then we implemented that entire thing here. So this is how this journey keep on continuing. And whenever I talk about this, I always say learning never ends. Till today also, if there is a new techniques keep on coming. You see every day we see some new newspaper, now one step media, now again going back to sequential media. Now this new machine has come up. Now we are more talking about artificial intelligence into IVF. So in future, yes, there are so many things to be learned and supposed to come. So it is an ongoing process. That is what I feel.
So, sir, you started from very that time very primitive, we can say, And that time only books were available. We used to imagine how it will look. We used to think on our own and from the books only. And now the time has changed, everything available digitally, and we can imagine how the egg is looking, how the embryo is looking, day 2, day 3, everything we can see with the digital media. So it was really
Yes,
tough
yes.
time. So when you begin, how different were embryology labs, and what were the biggest limitations and challenges you faced that time?
Yes, basically, as I said, this is an ongoing, evolving procedure. And initially, on those days, we used to clean the entire lab with the mop, with the walls, the floors, and not much of the disinfectants used. At that time, only disinfectant which we commonly use was 70% alcohol. But then later on, it has been realized, and it has been so many papers where came up that alcohol is toxic, it produces VOC, so alcohol should not be used. So then it is replaced with ammonium compounds, and now we have various other compounds which is used for surface cleaning and all. Similarly, air quality. This all has come along with the experience. As we see that the embryo is good, but implantation is not there. What may be wrong in that? Contamination. Previously, in 90s, if you see, the chances of contamination was high because we were not having that kind of facilities which is there today. So these all things keep on happening, developing. At that time, we used to have a normal microscope, stereoscope microscope. Now we have very high magnification microscopes. That time we used to have without heating plates, the laminar flow. We used to keep the separate heating plates. Now it is integrated in the laminar flow, which has improved a lot, and our stress is also reduced, maintaining the instrument, maintaining the incubator. So many things were there. Nowadays, we have automatic sterilization procedure. In those days, we used to clean incubator first, then we have to sterilize it, and then it is a long process. One long process, 3 4 days time it's taken. Now we have incubators which can be ready within 24 hours for the work. So that's how this whole thing happened. So if you see the lab totally designed and the concept of lab in 90s and now in this 25, it is totally changed. We are more concerned about the air quality. We are more concerned about the culture conditions. We are more concerned about the instruments. And instrument also, I feel that initially when they started appearing in the market by various international companies were there, then Indian companies started making it, so slowly, the cost initially was very high, but then the cost also reduced down. So more and more implementation, and you see the difference is that in 90s when I talk about 90s, that time might be 10 IVF centers all over India were working actually, but now we have more than 5,000 centers. So you can imagine the tremendous growth of this field, and this is something which is really interesting when you see a patient who conceived with your efforts with the ART lab treatment and all, and the smile on their face, that gives you a different kind of satisfaction. So that's how the things are.
So, sir, rightly said by you, the smile on the face of the patient is really the biggest gift we get in our life. It is priceless gift, I think. And in India, particularly, people were struggling with infertility. As you said, that there were only 10 centers. Now there are 5,000 centers because infertility is rising in men, women everywhere. And जो शब्द होता था बांझपन, people were hesitant to get treatment also. Now society is open to get the treatment. They are coming openly for the
Yes,
IVF. So
yes. Lot
very
of changes,
correct.
lot
Yeah.
of changes. Yes.
Correct.
And
At
they
the
are well
society level
educated.
also.
Yes. Now the couple is also getting education online. So they know what is happening and what treatment we are offering is the correct way. And they will ask you questions also. You might be experiencing that in counseling. And that's why counseling has become a very important part of your setup now. Patient has to understand and patient has all the rights to ask you.
Yes, sir. It was in the mind of many rural people that IVF baby will be looking something different. So that
Yes.
was the time when we started our practice. So rightly said by you. So, sir, which was the early breakthrough truly transformed embryo survival and pregnancy rates? Because you have witnessed more than 3 decades. So, what was that breakthrough?
I think the biggest breakthrough was the availability of ready-made media, culture media, and the disposables. Because when I started at that time, we used to reuse the disposable, wash it, again sterilize it, ETO sterilize. Now we don't have more ETO sterilized things in the lab. Now it is gamma radiated sterilization tubes and all. So I think that things started changing once this all imported media and the disposable pickup needles they started appearing in the market. That has reduced the stress. Like I remember, I used to make the media a day before for the patient who's undergoing pickup. So we used to take the serum of the wife, deactivate that serum, and then 10% of that serum used to be added in the flushing medium, normal HPS medium, as a culture media, and that is used as for culturing the embryos. But then we have replacement with the synthetic serum replacement compound and the ready-made medias were available. So this all and the risk was of infection only, contamination because taking the blood, then centrifuging it, separating the serum, and then deactivating it. So there are n number of places where any problem can happen. So I think the major breakthrough came only after availability of this. And initially, we know B2 Menazo media, it was an universal kind of media which was there in an ampule kind of packing. So for one patient, you just open it, use it, and discard it. So that's how this started. Then we came to sequential media, it all continuously developmental procedure in that then we came to know that okay, day zero the requirement of embryo is different, day three is different, day five is different. So accordingly they have formulated the media so that the embryo should not be in stress, because at any point of time you have to understand one thing very clearly, that embryos or gametes whatever it may be, whenever it comes outside body, it is in the unnatural environment where they comes under stress, and what you are doing is you are trying to reduce that stress by providing them the optimal culture conditions. So now sequential media, after the sequential media again there are new developments happen, and then the concept of why, who are you to decide that embryo wants this now, it is let's embryo choose. So that's how that concept of single step culture media, that is from day zero till day five, same medium. So let embryo decide what embryo wants, and that can be picked up by embryo, and the embryos is good. Now again, few school of thoughts are saying that no, this is not a correct way. We should give the sequential media only. So this is all keep on happening, but what you ask me question is the proper breakthrough has come only after availability of this all international standard products in India. And now you see more than 20-25 international companies are representing themselves in India as they have their offices in India, and they have proper network in India because there is huge market and there is huge number of centers have come up now. So, and I don't think that any center is doing less than 5 cases a month. Minimum 5 cases very easily every center is doing. So you can see the number of cases done every year. That is why the documentation is now required, so that at least we should know that how many centers are there and how many cases we are doing. And accordingly, the consumable market is there.
So this is really like very interesting to know that you used to make media from patients' own blood. That was really so difficult
Because
time.
that time this ready-made media concept was not there. So we used to use Earth's balanced salt solution as a base solution, which was available from the Sigma chemical company. That is the only formulated and chemical grade or good grade media available. So we only have to add this serum and use it for the culture. That is the only choice which we were having.
So you used to take sample 48 hours before, like during the time of
Yes,
trigger, you
yes.
collect
At least
the
2 days.
sperm.
2 days before 10 milliliter of blood is withdrawn, then it is centrifuged, serum is separated, then it is deactivated and by heating, and then that deactivated serum is filtered through 0.22 micron syringe filter. And though that filtered serum is used for the patient's embryo culture. We used to make the pipettes
So
also at
that
that time. So it was totally different scene. If today, if any embryologist learning today, if they see all these things, they will not believe that this is also possible. This is how everything started.
so your generation has put a lot of hard work, and it was really so great breakthrough that transformed embryo survival and success rate. So, um, sir, how the technology and standardization improved embryo development and consistency of outcome. So that's why a high quality embryology lab, which we call today. So something about this.
Yes. See, whenever someone asks me, sir, what is the success rate? What should be success rate in an ideal lab and all? So, if you consider today's scenario, when you have world-class disposable, world-class laboratory setup, world-class media available, and the patient management is also very good now. So, as far as I am concerned, I feel that with all standard conditions, you should be landing up somewhere at 30-40% minimum take home baby rate in IVF center in any ideal setup. Previously, when we started all these things in India, that time it was hardly 10%. Sometimes there is number of cases were also less. But then this embryo quality has improved when the culture conditions improved, and culture conditions improved because of availability. Now again, this development of culture condition is also gradually happened. It was not happened like that all of a sudden modular lab concept came. We used to have a positive pressure module. So this positive pressure module used to suck air from outside, pass it through a filter, HEPA filter, and it creates a positive pressure inside the lab. So the concept was whenever you open lab door, there is always from inflow to outflow. So the chances of contamination, chances of VOCs, chances of getting other contaminants inside is less. Then we had in-room filters like Coda Tower as concept comes, so that keep on circulating internal air and filtering it and removing the VOCs and all. So that's how the environment has improved. Then previously we used to have the walls, normal walls of the lab. Then it is suggested that to maintain it and to clean it properly, it should be tiled. Then the tile was up to 6 feet height. Then the concept came, no, no, you should have it till the top roof so that the entire thing should be very well cleaned. Now at that time, small tiles were available. Now we know 6 by 6 tiles are also available. So that reduced number of joints. So then it was advisable that you should use this kind of tiles in it. Now totally different. Now it is the modular lab. You should have an entire thing modular stainless steel lab, at least lab and OT. So this is how the gradually things has happened and culture conditions improved, and that's how the embryo improved and embryo quality improved. So it ultimately land up in the improvement in the results, and that's why I said that any standard lab offering these services should have somewhere around 30-40%. This may be 60%, sometimes this may be 20%. On an average, you should have 30-40%. If pregnancy rates are coming, then you should be very happy.
Sir, this is a beautiful journey of the culture from patient to now the best culture media we are using. So, from your experience, which current advances like vitrification, time lapse, PGT, and now AI tools, which have had the greatest real world impact?
Again, I a little bit have a different opinion on this because what happens that this is all international companies driven market. So you have to understand that the thing which is applicable in London, for example, in UK, you cannot blindly apply that to Indian scenario. You have to wait and watch. You have to see what is its impact. So as you rightly said that there are so many new things has come up, like this time-lapse incubator. And this is something which is really useful. You can, without disturbing embryos, the biggest advantage is without disturbing the embryos, you can see the development of embryo from outside, and you can have a better uh, um, uh, development of embryos because there is undisturbed culture. Better time lapse. So, time lapse doesn't happen, means time lapse does not give you addition to selecting embryo, rather than it is deselecting the embryo. Because you come to know that, okay, this embryo has first gone to 4 cell and now it is fragmented, so we cannot use it. Because after day 2 or day 3, you see all of them are 8 cell. So in between what happened in the developmental stage, we don't know. So selecting of embryo, that has become, quality of embryo has improved. Then AI, yes, definitely, because ultimately at some point of time you feel that you are seeing a 2D image. So now there are concept of 3D image embryo from all sides they see, and then they have an algorithm feed it, and with the help of software they come up with that this is a grade 1, this is grade 2, there is a different classification. Similarly, with the sperm, also these are, initially we all know that the sperm analysis or semen analysis was simply lying with this slide preparation, a drop on the slide under microscope. If there is moving sperms are there, it's a good sample. Sperm is not there, azoospermic sample. But now we know azoospermic can be a obstructive azoospermia, so we have to find out the reasons for that. Similarly, lots of sperm preparation techniques has come up, which has improved the sperm quality. So gradually this has happened, and now we have everything which is latest available. Now this AI, what we are talking about, there is various time this debate was there in various conferences, various events, that are we looking that AI is going to replace embryologist in future? I don't think that it is going to happen, because AI is ultimately what we give them, what algorithm we give, what algorithm we decide. AI help, with help of that algorithm, give us a conclusion. So they cannot just do. Recently, in one conference, they were talking about robotic ICSI, robot doing ICSI. Remote surgery is not an this thing big thing now. You can see so many surgical procedures happening there, sitting somewhere. From there, their robotic operations are there. So they are thinking that this is possible even for performing ICSI also. I am sitting at my home and I am with this robotic, I can do that also. But here the important thing is robot is not going to fix the needle. Robot is not going to fix the dish. We need some technical person over there who will set everything, and then the robot will perform. So yes, these all things are supposed to come in this field, and we expect in another 5 years or 10 years or so down the line, so many new things has come up. Like you said about vitrification, concept of freezing totally changed once this vitrification came in picture, because when we were started at that time, this freezing concept came around 95, 96, and there was a programmable freezer. That time we used to do slow freezing. A slow freezing is a controlled freezer which gives you a down rate of say minus zero point 0.1 degree or 1 degree centigrade per minute to keep on cooling. We know from room temperature of 37 degree or 32 degree or 30 degree to minus 90 degree till it goes inside liquid nitrogen. So you can imagine the time required for that process. So 3 hours, 4 hours program keep on running, and we used to freeze, and then when thought the survival was not that good. But now once this vitrification entered in picture, this has changed totally, because now the time is very less, recovery is good, and more number of embryos has also increased, because we now have minimum 10 oocytes or 12 oocytes coming, out of which 6 or 7 embryos are formed. And more of us are now doing single embryo transfer or a blastocyst transfer, which is mostly one blastocyst, good blastocyst with transfer. So we have a lot of embryos for freezing. So that's how this freezing technology has improved a lot. And now we are talking about rapid vitrification, which is further less consuming, time consuming, and giving good outcome. So yes, this all has changed the this scene of embryology totally different, and that's how it's in some meetings whenever I have this chance of interacting with this young generation of embryologists coming up, I tell them that you are very fortunate that you have everything ready-made available for you and you can start working. And at that time, very few people were there, and how they used to work and what they cannot even think of that how the things were there at that time. Now they have everything available on Google. They just keep on searching and they will find everything. So this is the difference.
So, sir, like young embryologists should be aware of how this evolved over the period, how much hard work, how much patience you have devoted for this thing. And as rightly said by you, that from slow freezing that was taking 3 4 hours, and then vitrification, now rapid vitrification, that really changed our um, and like tremendous change in the outcome and all the efforts. And similarly, like time lapse has improved selecting the embryo, because I remember opening the incubator after ICSI, seeing 2 p.m. and then day 2 day 3 or like that. And so these two
We
changes
we
I
we don't know at that time that what has happened between 2 p.m. stage to 8 cell embryo. There are lots of changes happened. So with the time lapse, at least you can see that what changes are happening, and accordingly you can select out which embryo you want to transfer. And patience,
and
as you said, this is the biggest quality of an embryologist should have. One embryologist is perfect embryologist only when he has patience, because many times things doesn't happen as per your wish. So you have to have patience and do it slowly, gently, and then it ultimately happens. But then you have to have patience. And this, what you are saying about this new generation, I always say that one has to understand that embryologist job is not just doing ICSI or doing IVF. Embryologist is the core of embryology lab, and he or she should have the all responsibilities should be taken and shared. Okay, you don't do yourself. Like at our time, we used to do everything ourselves. You have the staff, get the things done, but then it is your responsibility to get the things properly done. Cleaning is done properly or not, lab record is maintained properly or not. This everything is our responsibility. As an embryologist, we are responsible for our lab performance. So you have to see all aspect of the lab.
and so now from PGT to spent culture, that is also evolving, and I think in future uh, it will be. So
Yes,
something
because
about this.
this whole concept has started because as an infertility practitioner, when patient comes to you, you tell them that okay, this is the best technique available. We will do ICSI and we will see, and you see very good embryos, very good blast is formed, and once you transfer and the pregnancy test is negative, then patient comes, मैडम आपने तो बोला था, आपने जो बोला हमने सब किया, आपने कहा ये दवाई लो, ये इंजेक्शन लो, सब हुआ, फिर भी प्रेगनेंसी क्यों नहीं हुआ? And we really don't have the answer to that because we don't know what has gone wrong. So that's where this genetics entered in, and then we started thinking that there may be some genetic abnormality in the embryos. So yes, PGT is a technique which is offered to these patients where the embryos are analyzed for genetic anomalies, and then the normal embryos are selected and transferred. But then again, we have to understand that this is not a very common technique and very easily performed technique. Embryo has to undergo a great stress, and then you cannot transfer in fresh this thing. You have to freeze that. Once the report come, then you thaw them again, and then you again transfer. So it's time consuming and problem for the embryos also. So yes, but like if 2 3 cycle failure patient comes to you, yes, PGT is a good option to offer them. Now we have PGTM, PGTA, so many other things are available. Easy and less time consuming techniques are available, which gives you report earlier. And then this metabolomics, proteomics, this has come spent culture media. This has changed the entire thing because in this, what we see is the culture medium, spent culture medium. Now, what here we do is we take that small portion of the culture media where embryos are grown and we analyze for the metabolites present in that media. And depending upon a particular metabolite, like a good embryo produce this kind of metabolite in high concentration. So we analyze that if that is in high concentration, we select that particular embryo. And here there is no invasive procedure involved. There is no laser aging. There is no hole creation. There is no blastomere biopsy. It is the spent media. In PGT, you have to have a biopsy done. Embryo is punctured, then you have to take out a cell blastomere, then that cell undergo genetic analysis, and that's how you come to know. So yes, this is the technique. In future, it is further developments and modifications are coming up, and we are looking for the much more better techniques and advantages. And this metabolomics is a fantastic concept, although it is still in nascent stage. It has not up commercially, but very soon, I think we will have this also as commercially available tool for selecting the embryo.
Sir, now we realize that environmental factors affect fertility. So many types of pollutions, air pollution, noise pollutions, even affecting the male fertility. And there are so many literatures and this new committee, Environmental Health Committee, Fogsi has started. So I was also reading a lot, many literature. There is effect of all these pollutions, oxidative stress. So, what is the embryological impact of these microplastics, endocrine disturbers, pesticides, and heavy metals? Do you feel any difference in other countries and in like we are heavily polluted places?
Yes, this difference one can feel because as you said that these pollutants and all, how see that doesn't affect the gamete directly, but indirectly when they entered in the body, they change the metabolism, they change so many things system in the body, and then ultimately that changed metabolism affect the quality of gamete. But here, not only the environment, what I feel is the lifestyle and the behavioral changes which has happened now. Initially, we saw this trend in particularly IT industries and other industries that okay, we just want to spend some 5-10 years after marriage and then we will get the conception and pregnancy done and child bearing and all. And now the things is totally different. ठीक है एक बच्चा हो जाए उसके बाद फिर देखेंगे. So the thing is, this has everything has impact on the body directly, and ultimately that has converted into this. Now, plastics. This is a very well-known fact that the sperm count is decreasing. There are so many studies now available on that. You can just go through and you can see. Now, all of them are saying that this is just because they are more exposed to the radiations. They are more exposed to the this plastic. They are more exposed to the unhealthy food, which they come not timely taking food. So many things are there to be considered. And uh, I have personally experienced this in few cases, like when patient comes referred by some friend that, okay, you go and meet him, he will tell you that. And when you talk to them, you realize that there is so much of stress is there that patient is not in state of mind is not in state that they can plan this thing and so, and many time it has happened that I have just told them that for next 3 months you take a leave, don't do anything, just be at home or go outside somewhere. And the second important thing is the social impact. You see what happens that your own family, your people are not worried about, but the nearby people or your relatives, they start talking about, oh, शादी का 4 साल हो गया, अभी तक बच्चा नहीं हुआ, you should consult a doctor, you should see and all, and so many social stigma and stress for both parents. So in this case also, I tell them simply कि अभी यदि तुम्हारी मदर भी तुमसे इसके बारे में बात करे या तुम्हारे फादर बात करे या कोई भी बात करे, स्ट्रेट वे आपको एक ही जवाब देना है कि ये हमारा पर्सनल मैटर है, हम निपट लेंगे, आप इसके बारे में हमें सलाह ना दें. और आप मानेंगे नहीं मैडम, दे आर सो रिलैक्स एंड टू और थ्री ऑफ देम हैज कम अप विद अ नेचुरल कंसेप्शन. So just it was because they were under so much of stress there, and stress creates lots of problems. So this is also taken into consideration. So environment, stress, lifestyle, this combined factor which is affecting the fertility potential of the couple, and really it's going to be a tough time now in future also for them, because daily we are seeing in Delhi the AQI index is this, and recently I was in Delhi. So once you land in Delhi, you start feeling that breathing problem and congestion and all these things, irritation in eyes. So we don't know exactly what is the effect of this, and all the environmental changes are going to come. But yes, it is there, and we have to take care of all these factors. Then only we can have a good fertility potential.
So, sir, do you feel that this bad air quality, it increases DNA fragmentation or
Yes.
mitochondrial dysfunction? Have you observed yourself in some areas, like very, very polluted industrial areas, whatever this HEPA filter or this inside filters, whatever air quality we are giving to live, if air quality C, it is going to convert into B or A. So just want to ask this thing from you.
Yes, we have now all latest technology available. Like as you rightly said, it is filtered air is passed inside through AHU, air handling unit, where you can maintain the temperature and humidity. The two important things required for maintaining culture condition is the temperature and the humidity to have good embryo development. So this is very well maintained with the help of AHU, and AHU helps you out in filtering the this volatile organic compound also, and the impurities which is there in the environment. Similarly, the culture, as far as this embryo or the gamete is concerned, the like if we talk about male gamete sperm, then the DNA fragmentation is now very much in picture. Now you have to understand that 30 years back there was no talk about DNA fragmentation. Why? Because that time this all situation was totally different. People are not under that much of stress and all, and not much of the pollution. But now this has increased considerably. It doesn't mean that DNA fragmentation was not there, because body has its born mechanism of correcting the errors. So even if the DNA fragmentation is there, like even embryo also has inborn corrective measures can take, and what we see in the form of fragments is basically the waste product which was there, and it is naturally removed by the embryo. But when it increased to a particular level, then it has started giving concern that yes, we have to take care of this also, and so then medication and the lifestyle change and so many things we have to apply, and then we have to first get this DFI better, and then we plan the form for their IVF cycle. Similar is for the female gamete also. There is lots of changes has happened, and PCOS and endometriosis, these are very common thing which we are seeing in females. So that has also has somehow they are also connected with the this environment or their situation where they are living and the stress under which they are working. So many things we have to consider in this.
Sir, your recommendation, day 3, day 5.
Just few days to yesterday only we had a webinar on this day 3 versus day 5. So in this, my take home is very simple. It depends on patient factor, age, number of embryos, number of oocyte recovered, quality of those embryos and oocyte, sperm quality, and then previous IVF, how many cycles failure. These all parameters you have to consider, and then you have to give a thought that whether you want to do day 3 or day 5. Like previously, if someone has come to you with a blastocyst transfer which is failed, then why you will again plan a day 5 transfer for them? So better to transfer, because as I said, after day 3, the genome activation happens and body has its own mechanism of repairing. And so even if there is some problem, their body will take care. Initially, when this all started, we used to transfer on day 2. Then the concept came that no, you should transfer on day 3. You will have a better scene of the embryo. Then concept come day 5, and now we are talking about day 7. So ultimately, you are exposing embryo to the artificial environment for a longer period. Yes, you are providing good culture conditions. You are having very high quality incubators. You are having very high quality conditions, and everything is there. But still, ultimately, it is outside the body. So, better you transfer it as early as possible. In the best possible ways, then you have to consider this factor. If you have only three embryos, what you are going to do if suppose none of them convert into blastocysts? So the cycle will be cancelled. So better you transfer at least in the day three stage, whatever is going to happen, it will happen. And similarly, reverse is if you have 10 embryos, then better you select embryos. If you culture them till day five, you will have good embryos converted into blastocysts. You can select one blastocyst, and as we said just now, that vitrification as an gold standard now, and you can freeze the square embryos. So this is how. So for me, day five or day three, it all depends on the conditions of that patient. It should not be blanket kind of thing that you want to do day five transfer for everyone. It is condition dependent. You have to see the situation and then take a call.
So it should be shared decision. Patient, clinician, embryologist all should sit
Yes.
together. Prior history, there should not be single rule
Yeah. So,
applicable to each
so
and every.
here, what I want to emphasize is here that cross connect clinician and embryologist come in picture. Initially, when we started, there was not that much of communication happening, but now it is very regularly done. Clinician give importance to the embryologist thought that whether this embryo, what is the quality of this embryo, what is the potential of this embryo, should transfer it or should not transfer it. We should counsel patient till last. This is all is communicated, interacted, and then a collective call is taken. And most of the places now it is embryologist who is explaining to the patient that this is your quality of the embryo, and that's why we have taken this much decision, and we are transferring to and remaining we are freezing. Previously, it was not happening. Previously, it was only the clinician facing the all plus and minuses, but now it is collective effort. So now, even if negative, we are also having that sense that okay, something is wrong and we have to improve something in this. So this is the difference what we are seeing.
So it's a really great discussion with you, how it was in past, how it is in present, how it is going to evolve in future. That is really great discussion.
Future is very bright for embryologists, madam, because this is a very growing field. So many centers are coming up every day. New technologies are coming up. Yes, what I can say is that this is a time when you see after blastocyst formation, there is a process called differentiation starts, right? So ectoderm produce skin and so similarly now this is stage for this young embryologist to differentiate. Differentiate in the sense doing ICSI is not umbrella. Now, after ICSI, there is genetics. You specialize in PGD. You specialize in metabolomics. You specialize in some other area where you can do some work related with embryology and come up with some research paper or some good research and all. So that we have to understand.
So that was I was going to ask you, what advice would you like to give young embryologists entering in this field, this
Yes,
beautiful world of embryology?
yes, madam. This is very easy to understand. As I said, the young embryologists, they are entering in this field, they should have patience. That is the basic quality of any embryologist because what at what time what can go wrong you doesn't expect, and then in that situation what best possible you can do, because you see when we used to select the sperm, now we have so much of techniques available for selecting sperm, but when we conducted one workshop of this WHO on semen analysis in I think 2014 with the Academy of Clinical Embryologists, so that time I asked this question that suppose all embryos, all sperms are abnormal, then what you will do? Ultimately, you have to do ICSI and you have to give the embryo. So in that case, what you have to do is you have to select most normal looking sperm out of all those abnormalities. Understand? So you have to have some criteria. You have to select the best possible sperm and then inject. So patience. That is one thing. Second thing is lots of new era and areas are there for these young embryologists to explore. They should do much. And what I believe is we are probably doing highest number of cycles in the world. It's not documented, so we don't know how many. Even if today also this national registry, as per national registry record, if you see there are 3,000 centers only, but there are more than 5,000 centers running. They are not still registered. They don't have the basic infrastructure or whatever it may be. But what I feel is that we can do wonders in embryology if we take it passionately, we take it seriously. And the best thing, what happening here today is that all things are online available. Clinicians are very helpful. Society is helpful. Embryologist as a subject, embryology as a category has been selected. One small example I would like to give, which I always give in my this kind of discussion. When I wanted to construct my house, so I applied for loan. At that time, I was working as an embryologist. So when I applied for loan, they asked me, "Sir, what is your specialty?" I said, "Embryologist." So embryologist was not category there, any doctor, engineer, lawyer, IT professional, but embryologist were not. So they were not able to understand that what how you are going to repay the loan. So, but now the thing is different. It is there in there. This that embryologist is a branch where people are working, and so much things are happening. So this has come with time. So my advice to these young people is that they should keep patience, they should keep on learning. For me also, to as of today, even after spending 33 years, there is a lot of things to learn. If I say that I am a perfect embryologist, no one can be perfect. Learning scope is always there. They should keep on learning and understand. And the most important thing which I come across when I talk to these young embryologists, they say, "Sir, ICSI आता है हमको." So please understand, doing ICSI is not embryology. Embryology is much beyond that. So many things are one embryologist has supposed to do.
Great, sir. So it was great discussion, sir. And with people like-minded like you, clinician, embryologist, I hope India can lead as a global leader in embryology with ethical and high quality embryology labs.
I
I
am
hope so, sir.
100% sure, madam, it is going to happen. You see, because we have a lot of potential. Only thing is, it's not explored properly. But now there are our representation in international level. Also, we are representing our country. So definitely, yes, the future is very bright, and they will definitely come.
So, sir, now I think society should know that the behind IVF lab there are silent heroes. They are embryologists. Thank you so much, sir, for spending
Thank you
valuable
very much,
time
madam.
on and wishing all my viewers very happy 2026. Wishing you very happy new year, sir. Thank you so much. Thank you,
Thank you,
sir.
madam. Thank you.